Hello, and welcome to Health is the Key, the podcast that explores the health and wellness issues that matter to 1199 SCIU healthcare workers. I'm your host, Elizabeth Moore. In today's episode, we talk about the health screening that no one wants to talk about, the colonoscopy. Getting screened for colon cancer, the second most common cancer in the United States, can be life-saving. In fact, colorectal cancer cases overall are on the decline because more people are being screened. But unfortunately, cases are rising in people under 50 at a later, less treatable stage. So we're pleased to be joined today by Dr. Renee Williams, a gastroenterologist and associate professor in the Department of Medicine at NYU Langone. Dr. Williams will help us understand the numbers, explain the screening options, and offer some much-needed reassurance. Welcome to Health is the Key, Dr. Williams.
Thank you.
Let's start with some good news. Cancer cases are on the decline because more people are getting screened. So it seems early detection is key.
Yes, I think some good news is that since the 1970s, we have seen a decrease in colon cancer mortality or deaths from colon cancer and incidence, which is people getting diagnosed, by at least 54%. As much as people are getting screened, not enough people are getting screened. I think, unfortunately, we've had screenings for 25, 30 years, and we always wanted maybe 80% of the population get screened, but we're not at those numbers just yet.
And I know that they did lower the screening age to 45 recently.
Yes. What they found is they think they can save more lives by screening earlier. And as you mentioned, we're now seeing colon cancer in patients under the age of 50. It's what we call early onset colon cancer. So just to explain, in people over 50, we're seeing a decrease or drop in people getting diagnosed or dying. In patients before 50, we're seeing an increase. So if you're looking at men specifically between the ages of 40 to 49, the number one cancer killer right now is colon cancer.
Wow.
And in women in that same age group, the number two cancer killer is colon cancer, with the number one still being breast cancer. So it's a big area of research for our group, for our field, because we're trying to understand why it's happening. We don't understand. We think people born after a certain time point are just more prone, whether it's due to increasing rates of obesity or diet, more Western diet. We're not sure, but we're looking into it in a major way because it's an area of concern. So what I tell anyone who's younger, if you have bleeding in the stool or blood in the stool, in the past we would say, it's hemorrhoids, don't worry about it. Now we're saying get a colonoscopy.
Wow.
Don't have anyone say it's just a hemorrhoid. Get a colonoscopy because we're seeing a significant rise in cancer before. And not just colon, in other areas also.
I did want to ask you about that because I have heard that there are some symptoms that can be troubling, but don't necessarily mean colon cancer. So how do you know when, such as, upset stomach or diarrhea or IBS, how do you know when you should see a doctor?
I think it's hard. I think if you're losing weight, that's not normal. If you're seeing blood in the stool or you're vomiting blood, that's not normal. If your appetite is changing, that is not normal. If you're someone who's had diarrhea for 10 or 15 years, then that's a very different story than if you had diarrhea for the last month or 2 months. Now, that being said, if you have an infection, you went traveling and you have a diarrhea that resolves, that's fine. But any persistent symptoms, that like abdominal pain, that's not going away, it's important to get it evaluated. And something I like to tell patients is, your body. You know what feels normal and what does not feel normal. So if something feels a little bit off, I think it's okay to speak to someone about it. Even if it's nothing, it's better to get that checked out than to not get it checked out.
And are there certain conditions that make someone more prone to colon cancer?
Yes, there are certain genetic conditions that exist in certain families. And depending on the genetics, you may need to get a colonoscopy more frequently. Patients who have inflammatory bowel disease, you've seen the advertisements for ulcerative colitis. They're at a higher risk for having colon cancer, so they get screened again every 1 to 2 years versus everyone else. Depending on your family history, if you're someone who has a first-degree family member who had colon cancer, you are at increased risk. So meaning, if your mother, father, brother, or sister had colon cancer, then that means you get screened earlier. And you may need to get screened more frequently depending on the age of diagnosis of that first-degree family relative. So if your parent gets colon cancer, say age 50, then you should start getting screened at age 40. and you should get screened every 5 years. For an average risk person, someone who has no risk factors, we recommend every 10 years. But with a family history, and if you have multiple family members who have different cancers, you may have a genetic syndrome. So there are different genetic syndromes. And we say if you say an aunt had endometrial cancer or uterine cancer, and someone else had colon cancer, and someone else had gastric cancer, you may want to talk to your physician about getting some sort of genetic testing or screening.
So just cancer in general could be a risk factor.
Yeah, there are different types of cancers that are associated with certain genetic, something called Lynch syndrome. It's seen in families in different levels, grandparents, parents, and you being the primary person. So it's important to know your family history and to tell everything to your primary care doctor. And I know depending on who you are, you may not know these things, but it's important to ask.
And again, this is what we began our conversation with. This is something people don't like to talk about so much.
Yeah, but colon cancer specifically is preventable, it's treatable, and it's beatable. You catch it early enough. If you have there are different stages in all cancers, stage 1 to 4. If you have a stage 1 cancer, they can cut it out and that's it. You don't need anything else. No chemotherapy, no radiation. Just if it's stage 1, you just remove it.
That's what I think can be the most compelling reason about getting the colon cancer screening, because it's not only treatable if caught early, it's curable, which is amazing. Now we have to talk about the things that no one wants to talk about. The procedure, the colonoscopy procedure.
Yes. As I just said, having had my own colonoscopy recently and drinking the prep, I will admit it's kind of terrible. But to be honest, the preparation is worse than the actual procedure itself. Normally, we give you liquid to drink to clean out your colon. And I say to people, imagine looking through a glass that's very clean. You could see very well. Imagine looking through a dirty glass. You can't see very well. So essentially speaking, the cleaner your colon, the better for the physician. I can see more. I can do more. If someone is not very clean, then I may have them come back again for another procedure sooner.
And you don't want to do that.
Drinking twice. So for the procedure itself, we tend to do a couple of things. There is a preparation itself, which is medication you can drink. It's a liquid in most cases. There are some pill forms available. Traditionally, it's Go Lightly, which is 4 liters of fluid. However, there are other options that are less volume, and they're just as good as the bigger volume options. You drink that and you clear yourself out. Normally, we split it into 2 different dosage, the night before and the day off. What we've found is that if you do it as one go, you're not as clean as separating it. Number 2, the diet. That's not fun either. We tend to say a clear liquid diet. So nothing that's red. You can drink white grape juice. I'll admit, when I had my prep, I chased it with white grape juice because the prep was terrible. It didn't taste good. And I was like, oh, I feel very differently telling this to patients now. You can do jello. You can do broth. But no leafy green vegetables. That's roughage. So we say low residue before, because I've seen corn, I've seen vegetables. It gets in the way. I know it's counterproductive, but you should have a low residue or clear liquid diet the day before the procedure.
I think the thing that surprised me when I had my first colonoscopy was it was 3 days. 3 days before they told you to have a light diet. And I didn't really listen, and I had my normal diet, and they told me, yep, you're not clean enough. You got to come back.
That corn was hanging around.
So the prep, we know that's the worst part of it, but it's get throughable, and it's all worth it in the end. So can you tell us a little bit about the procedure itself?
The procedure itself, essentially speaking, you come in. You're going to speak with a gastroenterologist and an anesthesiologist who will go over the sedation. They put you to sleep in most cases. There are a few patients who do it without any sedation. I will say that. But in most cases, you'll see someone who's an anesthesia person who will speak to you about your medical history. They'll put you into a light sleep. Then we take a tube with a camera and the light. We go inside your bottom and look around your large intestines. If we see some residual stool, we tend to clean. And any polyps that can be removed, then we take it out. The only exception is if you're on a blood thinner. So if you're on a blood thinner, we tend to want to talk to your primary doctor. Can you stop it? If you're taking a blood thinner, certain medications for heart disease, we can't take out large polyps because you may bleed. So generally speaking, if you're on any of those medications, make sure the doctor knows, the GI doctor knows, because if you go in for the procedure, you do all this preparation, and you're on a blood thinner, we can't remove large polyps. In most cases, we'll ask you to hold it for 1 or 2 days. Depending on the blood thinner determines how many days we hold it, and then we can remove things.
Mm-hmm.
If you're diabetic, we also ask you to not take certain medications or maybe cut certain medications in half. So very important that your gastroenterologist knows your medical issues and your medications, because those all make a difference.
So they should have your complete history.
Exactly.
How long does the procedure last?
It's variable, honestly speaking.
Mm-hmm.
It could be 15 minutes or it could be an hour. It depends on, am I cleaning a lot? Because, most of us, if we see residual stool, we'll try to clean because we don't want our patients to come back a second time. Doesn't always work. Do you have a lot of polyps? I will say I've taken out 17 polyps in one go.
Wow.
So if you remove polyps, it takes more time. So I generally tell patients about half an hour.
So if your procedure does last an hour, that's not necessarily bad news. It's just there was more work to be done.
Yes, it's variable. If you spend time cleaning, removing polyps, I think most physicians, we want to make sure you don't have to come back.
Mm-hmm.
Sometimes you do. So we'll do everything to optimize the procedure then and there, but it doesn't always work.
Mm-hmm. And what can you expect after the procedure? Will you need to take the day off? Will you need to?
Well, the day off, we say sign no checks. Depending on the medications that's used, you may have some retrograde amnesia, meaning you may not remember what happened an hour ago.
Really?
Depending on the medications. So the day off, we say take your time off. You could eat anything you want. The main question I get after colonoscopy is, can I eat? What can I eat? I say, go crazy. Have a burger. Have some French fries because I know you're starving. And the next day you can go to work and do your normal activities. But the day off, we recommend taking a rest, taking it easy. And we normally want someone to come with you as an escort to take you home and just take it easy for the rest of the day.
Mm-hmm. So we know that the colonoscopy is a wonderful screening tool.
Mm-hmm.
What are some other options besides the colonoscopy?
So not everyone wants an invasive test, and we understand that. So you can also do a stool-based testing. I'm sure you've seen the ads on TV with Cologuard.
Cologuard, yes, which are covered by the funds.
Yes. Or you could do a FIT test. And what they're looking for is microscopic blood in the stool. So those are also approved as screening tests for colon cancer if you're average risk. If you have an increased risk, meaning you have a family member with cancer or you yourself had cancer or polyps, you have to get a colonoscopy. If you are average risk, meaning completely normal family history, you can do a stool test. Difference is a colonoscopy that's good and clean, you repeat in 10 years. The stool test, the Cologuard, is at every 3 years, and the FIT test is every 1 year. The issue there is it's a two-step process, right? If you have a positive test, you have to get the colonoscopy. So for someone who doesn't want to have an invasive test, not to drink the prep, you can ask your doctor, can you just give me a stool-based test? And recently, there was approved a blood-based testing.
I had read about that. I wanted to ask you about that. How accurate is that? I mean, the colonoscopy is still the gold standard. Can you talk a little bit about the blood test?
So in regards to the blood test, it looks for certain markers in the blood. And depending on those markers, if it's positive, we would refer you for a colonoscopy. I think currently at this time point, even though there's an FDA approval, we're still trying to figure out where it fits into the algorithm of screening. But it's always good to have another option in regards to colon cancer screening.
So we know that the colonoscopy and Cologuard are good screeners, but what about preventing colon cancer? Are there factors that you are in control of that you can help stave off it?
I think lifestyle, diet and exercise. Prevention is always better than the cure. We think diminish your processed foods. Processed foods in itself have a lot of bad effects on the body. So keep a clean diet if possible. Try to moderately exercise multiple times a week and maintain a healthy lifestyle. Obesity or high body weight is predisposes you to cancer and different kinds of cancers in the tract, not just colon, but other types of cancers. So essentially, I think, watch your diet, eat healthy, lower your processed foods, no burgers and French fries.
And even though you have one right after the colon.
I know, even though you have one, or a steak. Yeah, all the red meat is not very good for you. Smoking, bad habits, lifestyle things that you can do to diminish your risk over time.
The usual.
Exactly, the usual.
But are there some people who are more prone to it? We had talked about the conditions that might predispose. How are women more susceptible to it than men? Or
it's actually more men. You see it more in men compared to women. Yep. It's more men. If you're looking at differences in sex, it's men. Has a higher diagnosis in men than women, in general speaking. And of course, if you're genetically predisposed or if your family history.
And what about testing? Do men get tested more than women? I know women are usually the driving force behind their husbands getting tested or their fathers or brothers. Do we see a disconnect there between the sexes of who gets tested more?
Not necessarily. I think it depends on the physician. The number one predictor of getting screened is your primary care doctor recommending it. And I think that's where it comes into play. If your physician is not recommending it, I highly recommend speaking to them yourself and bringing it up. In women, screen for breast cancer. I think because women see OB-GYNs, there's a lot more screening happening. But if you have a primary care doctor, definitely say, what am I due for? I'm 45 or I'm 50. What screening test should I get done?
So if they don't mention it, you should.
You should mention it. I think it's important that patients advocate for themselves. I know sometimes patients don't feel comfortable, but I say if you're not comfortable with your physician, then find another one. I openly state that.
We talk about that a lot here at the funds too, having a good relationship with your primary care physician, knowing the questions to ask, making sure that you're being heard. And it's especially important for something like this.
You have to have a trusting relationship, or what I call a therapeutic relationship. If that's not there, and the trust isn't there, it's hard to have an honest conversation.
And again, this is a subject that is a little sensitive, so you may be hesitant to bring it up, so your doctor should definitely be the one.
Exactly. And some people don't like talking about their poop.
It's true.
Yeah. Or, it's like I said, if you have I mentioned constipation, diarrhea, that's new. Any of those things, important to talk about it. If your stool changes how it looks, meaning, if your stool goes from like a thick piece of poop to a very thin piece of poop or a very pencil thin stools, that's important to note because that may mean something is going on.
And that's not something people would really notice. That's a good thing to keep in mind.
Yeah. Some patients wash their poop. Some patients don't look at the toilets. It's a personal choice.
So you recently just had your first colonoscopy. I've had 2 now. Full confession, I don't mind it so much. I don't like the prep, that's for sure. But I told my family I would rather have a colonoscopy than have my teeth cleaned. Okay. So what advice or what would you tell our members to encourage them to get it? Coming from me, it's not so bad. Get it done.
I think, as I said, the colonoscopy itself is not bad. You're sleeping. So if I remember, I closed my eyes and I opened my eyes. And I was like, oh, we're done. I'm in a room with a warm blanket and getting some cookies and drinks, which I'm sure you did. I think having a conversation, I think knowing your family history is important and really breaching the conversation. I mean, in all honesty, the prep is not the best. I'm not going to lie.
And that's coming from a doctor, so we appreciate that.
But I think there are options. You can ask for a lower volume prep, where the prep I took, I had to drink 2 bottles of water plus a prep, which is much easier than drinking 4 liters of nasty tasting stuff. So I think just having an honest conversation with knowing your family history, speaking to your physician, and see. And some preps have flavors. I know there's sometimes I write like a lemony flavor thing. I don't know if it helps. I'm just saying it happens. But I think, just kind of buckle down, drink the prep. And as I said, I chased mine with grape juice. It helped a lot, to be honest with you.
I did the same. I did apple juice. It's a little sips.
Yeah. I drank and then I tasted it. And if you're taking the prep and noticing that you're feeling a little sick, which can happen, just slow down. It's okay to slow down.
That's good. Pace yourself. Yeah,
exactly.
Well, I think that many of our members know all this, and it's really doing it for yourself, self-care, and doing it for the people you love, being so that you can be around. And as a doctor, you're doing it so you can be around for your patients, and our healthcare workers are around for their patients and their residents and their clients. So it's one day out of your life.
Yes. And as I said, I have a lot more empathy for my patients now. Yes. And yes, of course, with the prep comes sitting on the toilet, passing,
Get a good book.
Get a good book because you're and you're not just passing gas. All I have to say.
So the one takeaway you would leave with our members,
I think, get screened. Choose a test that you're comfortable with. Not something I'm a gastroenterologist, so I'm going to say do a colonoscopy. But if you don't want a colonoscopy, it's completely within your rights to do a stool-based testing instead. And once we have more information on the blood-based testing, that's a third option on the table. So I think just get screened and have a conversation with your primary care doctor about what option is best for you.
As you said, the best test is the test that gets done. Perfect. Well, thank you so much. We really appreciate your coming in to join us and talk about this little sensitive subject.
Well, thank you for having me. I appreciated the invite.
Tune in later this month to our March keynote to hear Dr. Williams explain your options if your colonoscopy comes back positive for polyps. Just remember what Dr. Williams said, colon cancer is preventable, treatable, and beatable. For more information on what you heard today, please check our show notes. And remember, subscribe to Health is the Key wherever you get your podcasts. This podcast and its content are presented solely for general informational and entertainment purposes. The information and opinions provided on this podcast are not intended as legal or medical advice and do not constitute or serve as a substitute for professional medical or psychological treatment, diagnosis, therapy, or other types of professional intervention.